So now let's go a little bit more advanced. This is a 69-year-old male who also doesn't have cirrhosis, but has multifocal HCC. So this is an aggressive BCLC B, technically. Definitely no macrovascular invasion that we can see. Bilobar, really a dominant 12 centimeter tumor, kind of in segment 5-6, but also has some three additional small lesions up in segments 2 and 3. What does the discussion at your tumor board sound like?
Yeah, I'll jump in first by prefacing this by, I think there was actually a recent study that just came out that shows there is still benefit for multifocal HCC and resection, whereas historically we were like, once you have more than one tumor, you probably need to move in an alternate direction. That said, I think the disease burden and the locations of the tumors, I think surgical resection is not really on the table.
So I think in a case like this, there's, in my mind, no question that we need systemic therapy. I think the other question is, with the dominant lesion, would there be role for also doing a radioembolization to where you have that cluster of disease?
Yeah, I mean, at our place, this patient's gonna, if they're eligible, gonna get a clinical trial. And, most of our clinical trials have largely focused now on these advanced stage, bad terminology, but late BCLC B patients, right? Which this patient is. So let's say they were not interested in a trial. We would probably, then it becomes kind of this argument between systemic therapy and local regional therapy. My argument for a local regional approach is that, at least for systemic therapy, has really been studied in BCLC C. And when they looked at the BCLC B subsets, let's say we look at IMbrave 150, there's not a huge signal actually in the BCLC B subset. It's really in the BCLC C, or the advanced stage. So my preference is still to at least lead off with a local regional approach. They're Child-Pugh A, if they're functional. It depends really on how many of these small tumors you see. Zach has highlighted 3 of them. There may be more. We don't really know. It's hard to tell until you do an angiogram, and you may find 10 more. And so that's been our approach. And then the question becomes, do we tag it with a systemic therapy right afterwards? Do we restage and then consider systemic therapy? And those are kind of open-ended questions. This is where kind of the art of medicine comes into play.
I agree with you on point 1. Point 2, we may disagree on. All patients, I should have led with this like Heather did, should be offered clinical trials when available, particularly these patients that are, non-cirrhotic, well compensated. So whenever we have a clinical study, we know that patients with any types of cancer, including HCC, benefit from being offered clinical trial enrollment. So that would be my preference as well. I do think with this amount of disease by lobar, starting with systemic therapy is what I would offer the patient. I think that you lose little from that approach. And if you have someone that falls into that category of being a partial responder or even a complete responder, which we do see sometimes, we save that person the additional toxicity of a local treatment that they may or may not need. And at this point, we don't really have data would save or prolong their life in the way that we do the systemic therapy would hopefully improve overall survival in this standpoint. But I do think that, again, in the clinical trial space, the idea of combining local regional therapy and systemic therapy is very interesting, particularly for patients like this that have like a large dominant lesion, because we may find if we collect the data that it does help.
My issue with the clinical trial, or the data published for systemic therapy up till to date, there's no description on tumor size, tumor number, tumor burden. I mean, it's not there. IMbrave 150, what's the average tumor size? I don't know. Is it 5 millimeters? Is it 5 centimeters? Is it 50 centimeters? And so I have no idea, what types of patients were in these trials, because none of them, it's not just that one, even Himalaya and so on, none of them describe that. And so it becomes hard for us, if we're practicing, and let's say the patient was not a trial candidate for whatever reason, to say, well, will this patient have fit in the IMbrave 150 trial? I don't even know, because they never mentioned what type of tumors they were really treating in those. So I think that's one of the big shortcomings of the systemic therapy trials. They failed to disclose that. The local regional therapy trials, while by no means perfect, we've always talked about median tumor size, number of tumors, tumor burden, et cetera. So we kind of you get this picture in your mind of like, okay, in the Dososphere trial, this was the type of patient that they were kind of aiming towards.
Yeah, I hear you. I think that's a valid point. I do think for someone like this, though, you lose little by starting with systemic therapy and considering a consolidative tear further down. If those smaller lesions get smaller or go away, and it's really that dominant lesions that's still looking viable, most of the time we know we can at least safely combine immunotherapy and a tear, and that would be approach that we use often.
So for this particular patient, the day before they were supposed to get a tear, a surgeon came out of the blue and said, I can resect that, and we can do intraoperative ablation for those 3 smaller tumors. And so this is what it looks like after we did that. So had a resection of that dominant 12 centimeter tumor with intraoperative ablation of the 3 smaller tumors in segments 2 and 3. About a month after the surgery, after they've recovered, we get this scan that shows no evidence of at least disease that we could see. The patient did have microvascular invasion on pathology. Do we offer adjuvant therapy?
As I mentioned, earlier, adjuvant therapy is still really under active investigation. We don't know for sure that adjuvant therapy in a patient like this with atezobev at least would provide a decrease in recurrence or survival benefit. This person is extremely high risk of recurrence, and I do worry a lot about their trajectory. But I would say as of, again, today, we don't have proof that adjuvant immunotherapy would change the outcome here.
I'm a little embarrassed, I got to say. Did I prove myself wrong here? Yeah, it's a very interesting approach.
Are you embarrassed for yourself or for the guy who did it?
No, for myself. I might have been the guy who did it. I don't know. But yeah, I think that, again, if you can end up with no evidence of disease on imaging, then that's a win. And that makes, it's a sensible approach. It's a little bit outside the box, but it does make sense to approach that way, because in the end, that's what we're all after, right? To have a scan that looks like this, where you don't see any evidence of active disease.
Can I ask, does your thought process about that change if this is somebody who you have serial imaging in and you have a sense of the, rapidity with which they sort of develop this multitude of tumors versus somebody where it's a more indolent process? I mean, often we don't have that backstory, right? Like the first scan we have is the one that we saw in the last slide.
I think if you have something that shows a more aggressive tumor biology, then your systemic therapies might be a better option than somebody who's got more indolent and slow growing disease, where the systemic therapy is not going to be as robust. Response is not going to be perhaps as robust. So that might put surgery more at the front of the option list.
And would AFP impact your thought process? No.
Yeah, I don't know. I don't pay too much attention to that. I guess when it hits like 30,000, you're like, well,
right.
But it's just
like
hard.
If it was 30,000, and assuming that you didn't see evidence of extrahepatic disease, would you have resected in that setting?
Yeah, that's a good question. Well, I'm the guy who said no resection to begin with, so it's a little awkward to say what I would have.
I mean, you say you're embarrassed, but I think 9 out of 10 hepatobiliary surgeons would have not done this. Certainly, our hepatobiliary surgeons at UCLA who have a ton of experience resecting HCC, there's no way they are going to do a surgical resection on someone with multifocal HCC. It's just not part of most treatment algorithms unless there's a certain indication or special situation.
I do think this is a circumstance too where systemic therapy really helps you understand where the patient is heading. If there's someone that you start with that degree of multifocality and they're blowing through immunotherapy, they're not going to benefit from surgery. They're not going to benefit from transplant. They have an aggressive disease biology that we probably can't turn around with any therapy, and to subject them to a really aggressive surgical procedure may not be in their best interest. On the flip side of things, if there's someone that's responding well to immunotherapy, again, thinking outside the box, remembering Heather's point, if we can ever get a person to cure, we always want to maintain that kind of mentality. And if their disease is responding well and they're getting downstage, to kind of rethink those patients that are moving leftward in the BCLC curve.
So we treated this patient before Embrave 050 came out and gave them a year of atezobev. And now, I don't have the follow-up imaging for this particular patient, but they're still without disease over a year later. And I believe they're off atezobev now, right?
Good job, Dr. Schnickel, or whoever did it.
It was Dr. Schnickel.
Oh, wow. That's, I'm not sure how to, I don't listen to my own advice.